let's move on to our next presentation for the day. So welcome back, Gráinne from University of Strathclyde. I'll pop your slides up and get back to the start. There we go. And hand over to you to tell us about the workshop that you had fairly recently.
Thank you very much. My name is Gráinne McGill. I am a lecturer and Chancellor's Fellow at the Department of Architecture at the University of Strathclyde. So I'll be presenting a little bit of the Scottish perspective on this. Today I will be providing a short presentation presenting some of the initial insights that we gained from a cross-sector workshop that we held at the university back in August this year. Which was focusing on strengthening the links between the home health and healthcare pathways. Okay, so this workshop, it was part of a project that we're running from now for the next 2 years on home health and patient health. So it's well recognised that the home is one of the strongest determinants of health, and yet the home environment is actually still really rarely considered systematically within clinical settings. So healthcare professionals are trained to ask a number of different questions relating to things like smoking and diet and other lifestyle factors, but family or things like housing history and housing conditions are still not routinely considered by medical training or routine practice. And this is even when environmental conditions may actually be directly contributing to the symptoms that are being treated. So there's a GP that we would work with regularly would say things like that he'd be treating patients within a GP setting within a clinic, but he has no idea of what he's actually sending those patients home to. And this gap is actually really significant in the current landscape. So there's much more care now shifting into community settings, and it creates real opportunities to actually recognise housing related health risks earlier. So that'll be through things like home visits, community nursing, or even through routine GP consultations. So the focus of this project is actually about trying to bring greater attention to the home and how home is considered within GP and community-based care, offering a real kind of opportunity for earlier preventative action. Okay. So just to set the wider context for this project, it's part of a much wider program called Design Hopes, which is a transdisciplinary initiative that uses design-led thinking to address complex system-level challenges across health and social care. So the core aim of this wider program is actually to explore how design-based thinking and design methods could support Scotland's transition to a much more sustainable integrated net zero models of care. This particular project is part of Pillar 3. The project builds on earlier work that was conducted, which included things like a scoping review and a public exhibition, which was held in a hospital, examining how healthcare professionals and trying to gain feedback from healthcare professionals of how they perceive patient energy use and the links between energy in the home environment and health. And this next stage, which will be running between October this year for the next 2 years, is just looking at this much deeper into this gap with a focus much more on impact and engagement. And it's seeking to understand how healthcare professionals perceive and respond to the home as a determinant of health, and to identify what kinds of support would help. So whether that's through referral pathways, better screening tools, or targeted training, to better integrate the home environment much more routinely into everyday healthcare practice. So the aim of this workshop then, and the aim of this part of the project, is to help to develop a practical screening tool that allows housing related risks to be recognised much earlier and acted upon more consistently across the wide range of different services, which is what really led to the workshop that we held, which I'll discuss next. Okay, so the workshop was held back in August this year at the University of Strathclyde. It was an in-person workshop held over half of a day, which brought together 9 different participants representing a range of a mix of different housing professionals, public health officers, third sector leads, and some academic researchers. And it was structured around 3 key interlinked activities. So for the first stage, we initially had developed a range of different indicators on the home environment and health, which spanned 5 key domains, including physical environment, accessibility, overcrowding and safety, energy and fuel poverty, and psychosocial well-being. And that initial exercise then looked at these indicators that we had developed in more detail and invited focused reflection on the relevance, the clarity, and the feasibility of those indicators. Then the second stage was a group collaboration. So in small mixed professional groups, participants discussed different variations to an assessment protocol based on different types of roles within the environment. So from GPs to occupational therapists to housing officers, and how they might all adopt this kind of screening tool differently and how it would actually be used in practice. And then the final activity explored more related to things like gaps and potential refinements of any kind of home assessment framework. Okay, so some of the kind of key outcomes or findings that we had identified from the workshop. The first message was really clear, that the indicators that we had initially identified on their own were not really considered enough. Participants really strongly emphasized the importance of having some kind of a pre-screening stage to try to capture broader contextual factors that could shape how people actually experience their homes. So things like poverty, trauma histories, isolation, or even caring responsibilities, and these elements were really seen as essential to ensure that any kind of a screening tool would be used in an equitable and safe way. The second theme then was on the need for a much more holistic way of understanding the home. So participants questioned the very framing of the home, whether any kind of like a home screening tool should also include communal areas, outdoor spaces, garden areas, or aspects of the surrounding environment. And they also stressed the need for that the indicators themselves are actually deeply interconnected and linked in practice. Another important point was the recognition of invisible or seasonal risks. So, for example, winter moisture loads that could be missed if the assessment was conducted at other times of the year. The third theme then was much more around solution-focused design, so centered on how the tool would actually be genuinely usable in practice. So participants were really clear that actually identifying problems through any kind of a home screening tool without providing solutions could risk overwhelming households or professionals. So that was really clear, the need for up-to-date referral pathways and accessible support directories linked to any kind of a tool. And this was highlighted during the workshop as currently a major gap within the system. The need for shared protocols and cross-sector standards also came through really strongly, so that whichever professional actually would use the tool, the information is acted upon consistently and followed up appropriately. Participants noted significant data gaps, particularly around what actually happens after referrals are made, and called for better outcome tracking to support evaluation and refinement. Finally, there was agreement that any kind of tool must align with any existing and emerging frameworks, so things like AWAB's law, so that it can be actually embedded meaningfully into practice and rather than actually becoming what would be perceived as an additional burden. So overall, participants saw the tool not just as a checklist, but as an opportunity to actually build much more contextualized, holistic, and actionable approach to home health assessment across different types of sectors. Okay. Then finally, actually looking at real world use, there was, in terms of the tailored formats, the second activity focused on how the tool will actually function in real world settings and what would actually be required for professionals to use any kind of a screening tool in practice. A really strong theme that emerged was the need for tailored formats. So rather than a single universal version, participants envisioned that the tool would be used by a wide range of different roles, and given that kind of a diversity, they were clear that the tool must be adaptable for different workflows and different types of responsibilities. So, for example, a GP might only need a kind of brief triage checklist linked to referral routes, whereas an OT or support worker might require a much more detailed assessment or have the capability to do a much more detailed assessment of the home environment. Alongside formatting, participants identified several enablers that would be essential for implementation, which included things like the need for clear training and guidance, other technical enablers such as app-based walkthroughs, pre-consultation tablet forms. So, for example, a pre-consultation for a GP where patients could complete a form in the waiting area, or virtual inspection options were also suggested, allowing data to be gathered much more consistently across different types of settings. The final set of insights focused much more on data linkage and system integration. Participants stressed that the tool should connect with existing systems, so things like existing GP software, housing data sets, or local authority case management tools to avoid duplication and reduce workload. Secure linkage was seen as a really important for sharing information appropriately across different sectors. Finally, participants reiterated the need for shared referral pathways and cross-sector protocols. So it was highlighted that without really clear routes for action, so who does what, when, and how, that the tool would risk identifying problems that then end up falling between services. Then in the very final session, the discussion shifted much more from the tool itself to the wider system that would be needed to support it. So participants emphasised that the tool has the potential to act as a real lever for transforming how housing is actually valued within health and social care systems. So in terms of the key drivers, what was highlighted was that firstly, that the tool could actually help to reposition housing as a core component of health rather than an adjacent issue. Secondly, by linking housing conditions to health outcomes, that this kind of a tool could really help to enable services to model the longer term benefits of early intervention. And third, a data enabled approach could really help to underpin an economic case for upstream prevention, supporting investment in housing from across health and social care budgets, not only from the housing sector. So in terms then of system transformation, to realise that kind of potential, the system really needs to be ready to absorb and act on the insights that are actually produced. Participants stressed the need for established infrastructure, particularly things like funded referral pathways, clear lines of responsibility, and integration with existing digital systems. And without these, identifying problems could risk creating ethical dilemmas for practitioners. Cross-sector collaboration was seen as essential, requiring a culture and political commitment to joint work, and participants noted that the tool would be most effective embedded within procurement and policy or service agreements, and that might help to improve uptake in practice. Finally, in terms of adaptability, the adaptability was viewed as really, really crucial for long-term sustainability. So participants emphasised that the tool must remain people-centred, reflecting lived experiences and human narratives rather than only physical building conditions. It was recommended to have some kind of like a standardised core screening structure with them adaptable sections tailored to different types of roles or settings or levels of expertise, and that the overall system must support both crisis response and early intervention, ensuring that any of the kind of insights from a home screening tool could be acted upon across the full spectrum of need. So together, these kind of insights pointed to a wider ambition, so that if a home screening tool was implemented well, that it could really help to support a shift away from reactive kind of siloed responses towards a much more integrated prevention focused model of care. Okay, so that was just initial overview of some of the key findings that were gained from the workshop. So this project will be running for the next 2 years. As we move to the next phase, which is much more focused on impact and engagement, we're planning a series of different activities to try to deepen the evidence base and kind of look at co-design of practical solutions going forward. So we're currently preparing a short survey that we're hoping to circulate across different NHS boards and primary care practices in Scotland. And the aim of this would be just to capture baseline perceptions of the home as a determinant of health and current barriers, and where practitioners feel clear pathways or tools would be most needed. I'm particularly interested in how healthcare professionals actually perceive their remit in terms of providing advice on the home environment. We're also planning on undertaking 2 scoping reviews. The first one looking at any existing referral pathways that are used by healthcare practitioners based in the UK and internationally, and then also another looking at reviewing existing home health related screening tools and assessment methods. Alongside this, we plan to carry out some interviews and focus groups with healthcare professionals along with diaries to try to gain just a bit more insight into how and when housing related issues actually arise during GP consultations. And then towards later phases of the project, we would hope to organise a larger cross-sector kind of co-design workshop trying to bring together different players from housing, energy, health and third sector partners to try to refine the design of a screening tool or pathway and hopefully pilot some kind of a version for a real world setting. This is still kind of in development. We've just really kicked off this initial phase, so we're still really refining what these next 2 years are going to look like. And just before I finish, I also just wanted to mention a really short survey that we're currently circulating as part of a new NIHR proposal that we're developing, which is looking at the impact of household ventilation on respiratory health of children under the age of 5. The focus is in Scotland, but if it was funded within the first few years of the project, we'd hope to look at the feasibility of actually expanding that throughout the whole of the UK. So if there are any housing providers or local authorities in the call, that particularly if anyone has housing stock in Scotland, if you'd be happy to take part in the survey. What we're really hoping to do as part of the survey is actually to just gain an understanding of what data is currently being collected on ventilation provision and to look at the feasibility of linking that with national healthcare data to look at the links between household ventilation and health outcomes. So yeah, really interested if anyone would be open to supporting as a project partner. Would be really happy to follow up. Okay, so thank you very much. I just wanted to acknowledge the wider project team that is working on this project, including Professor Sonia Oliveira, who's the project lead, and also very much to the workshop participants who helped to share their kind of insight and experience during the workshop. And really interested if anyone has any ideas or reflections or anyone interested in contributing to the next stages of the research or any future workshops. I'd be really happy to hear from you. My email address is there. Thank you very much.
Great, thank you, Gráinne. It's kind of when you're going to the workshops, was there anything that surprised you or anything that you didn't kind of expect going into it?
Yeah, I was surprised actually with, well, the different perspectives from healthcare providers to the housing officers and how fragmented the current system is. And I think that is something that there really is quite a siloed approach to the provision of housing and then the kind of provision of healthcare, even though they are so interlinked and they have such a significant impact on each other. It was quite shocking just to see how even the systems and what we thought initially envisioned the linkage between housing and health, particularly in terms of like systems and how data could be shared, that's much more complex and challenging in practice. And it's something that maybe through the project it would be interesting to explore just how data could be shared more freely between housing providers and healthcare providers to have a better understanding of the impact of housing on health.
Yeah, data, I think is a minefield, isn't it? I mean, not just not just kind of interoperability assistance, but when you throw in GDPR as well, it becomes really problematic, doesn't it? To kind of share information.
We have a funded PhD scholarship that we're advertising at the moment, which we are working. It's part of a wider Centre for Doctoral Training, which is on energy efficient indoor climate control for optimised health. But as part of that Centre for Doctoral Training, we're working, so we're within the Department of Architecture, but we're working with colleagues from psychology and from our computer and information science department. And yeah, that was one of the reasons why we were particularly interested in collaborating, is that ability to understand the whole data and data science and how to link different data sets, and that scholarship would be kind of co-supervised with our computer and information science department to try to understand how to actually do that feasibly.
Yeah, need somebody very clever to do that, I think. And I think you kind of touched on there as well. I think if you, I suppose, kind of, you can tend to think that housing is one joined up sector and the NHS is one joined up thing. That could then link the two together. But I think you quite often find that there's different bits of the NHS all work in their own little silos, and there's little bits of housing all work in their own little silos. So it's quite difficult to find the bits that join together easily.
Yeah, and even within architecture practice as well, it's amazing how the impact of the design of buildings and how little that's actually considered. The impact on health is considered within architectural training and practice. And post-occupancy evaluation tends to be quite a small element of that.
Yeah, I know there's a study going on at University of Stirling around kind of the stigma of adaptations, which again kind of is looking at similar issues. Just had a question pop through from Martin about the kind of outcome impact evaluation period, and I suppose kind of whether 2 years gives you enough time to get kind of purposeful outcomes from that.
Yeah, so the 2 years, it's kind of more focused. So in terms of impact and evaluation, it's the first phase was meant to be kind of much more focused on the research and data gathering. We're still finding that there's still quite a lot of data and a little bit of research that still needs to be done in order to develop the screening tool. So the first phase will really just be about developing a pilot, and that might be such a small element. What we realized from the workshop is trying to develop a tool that encompasses all aspects of the home environment that could have an impact on health is quite a significant undertaking, and that we might be better to just focus on particular areas, whether that's the elements of the home environment that have an impact on things like respiratory health or something, that focus on that and developing a much more tailored part of the tool just to look at those linkages and referral mechanisms and data linkages and pathways in more detail, and that might be much more feasible within a 2-year project.
So were those?
Sorry?
So I was going to say, were those the priorities that came at the workshop? Was that kind of where it was leading you towards?
Yeah, and also like what the project is particularly interested is understanding healthcare professionals' perceptions of the home environment, because what we've found through the initial phase is that while healthcare professionals understand and recognise that the home is fundamental, is one of the key determinants of health, the remit or their perception of their remit as a healthcare provider, well, it depends on the GPs, for instance, or some of the hospital staff through that initial exhibition. It was very clear that they felt like their remit didn't really extend to the home environment, and their ability to influence the home environment was quite limited.
Mm.
So that's something that we're interested in exploring in a little bit more detail, is whether there might be opportunities for training or for some sort of a screening tool to be used by GPs to help better understand the impact of the home environment on the health outcomes, and how home improvements might help to also improve particular symptoms.
Okay. Yes. Yeah. Makes sense. Makes sense. So, do you want to give a final plug for how people can help you with the next stage of the project?
Yeah, well, if anyone is interested, particularly, so we've got the NIHR proposal that we're developing at the moment, and that's looking. Well, what we're interested with that is how household ventilation, because that can have an impact on health of children under the age of 5. And the reason why we're focusing on children under the age of 5 is mainly because of their vulnerability. They spend a lot more time in the home environment, but then also because we, as part of the project, we would have access to larger national health data across Scotland of respiratory health outcomes of children under the age of 5. So that would be a really, really unique opportunity to be able to link that at scale, to have much better understanding of the impact of not only ventilation provision, but also performance in practice, because we know that provision doesn't always necessarily mean that that's the way the home performs. So any local authorities or housing providers that have data on ventilation interested in contributing, I've got a link to the survey, but if you are happy to even contact me directly. And then, yeah, if anyone is interested in maybe taking part in any follow-up workshops and maybe join a mailing list, that would be fantastic.
Great, thank you. There's a couple of people on the chat there that kind of Callie in West Sussex. They've got a home audit assessment tool, and Adrian saying that it sounds very similar to their own breath of fresh air study. So
yeah, I can't wait to actually look at Adrian's study.
I think that's kind of one of the benefits of doing these things. It kind of allows people who've never met before to share and compare ideas and thinking. So thank you very much for joining us today, Gráinne, and thank you for coming back again after our full start 2 weeks ago. When would be a good time to kind of catch up with you again and kind of see what's emerged from the next stage of the study?
Well, maybe once we have rolled out the survey with healthcare providers and we've got some data for that, we'd be happy to share some of those findings.
Great. Well, thank you for joining us again today, and I'm sure people will be in touch via the email you've shared. So, thank you.
Fantastic. Thank you very much.